General handling and safety of dental materials in the dental office. Dental healthcare personnel use a wide variety of chemical-containing dental materials for patient treatment and laboratory procedures. All chemicals are capable of causing harmful effects if they are absorbed into the human body. The safety of the patient and the dental professional handling dental materials is of paramount concern. Safety for the work environment is a shared commitment of the dental team and the patient. Clinicians should be very familiar with the regulations for safe practice and the prevention of transmission of potentially pathogenic microbes to both patients and dental personnel. This chapter concentrates on how to prevent exposure to potentially hazardous materials. All dental personnel must understand the safe use, cleanup, and disposal methods for all materials used in the dental office. This chapter also discusses compliance with governmental regulations and explains health and safety procedures. Material hazards in the dental environment. Exposure to particulate matter. During the manipulation of many dental materials, particulate matter can be generated. Items such as gypsum products, alginate, microblasting, or sandblasting with very fine particle materials, and pumice may generate dust during handling. Gypsum modeled, processed acrylic, porcelain, and various restorative materials may generate dust during the grinding and polishing processes. Pneumoconosis is a fibrotic lung disease that can be caused by chronic exposure to these dusts. Black lung disease is the diagnosis for coal miners who got this disease from inhaling coal dust. It is important for each person handling and manipulating these materials to have and use the proper personal protective equipment, PPE, such as dust or surgical mask, eyewear, gowns, and when appropriate, hair cuttings or tieback. Appropriate exhaust ventilation in dental laboratories where grinding or trimming of materials is performed is equally important. Exposure to biological contaminants. Dental personnel come in contact with a variety of microorganisms through exposure to blood, bodily fluids, oral and respiratory secretions. These microorganisms may include hepatitis B virus, hepatitis C virus, human immunodeficiency virus, herpes simplex virus, or other viruses and bacteria. Dental personnel can be protected from the occupational transmission of infectious disease through strict adherence to the requirements of the Occupational Safety and Health Administration, OSHA, and the Canadian Centre for Occupational Health, CCOH, Bloodborne Pathogen Standard, and to the infection control guidelines issued by the Centers for Disease Control and Prevention, the CDC. A further excellent resource for the dental team is the Organization for Safety, Asbestos, and Prevention, OSAP. Most U.S. states have regulations specific to infection control for dentistry. It is imperative that dental auxiliary is familiar with both state and federal regulations and guidelines. Dental personnel must consider the possibility that equipment, storage containers, and dental materials may be contaminated during handling. Therefore, it is important to use proper barrier protection, such as overgloves or plastic covers with handling bottles, cans, tubes that contain many of the dental materials used in modern dental practice. Areas and equipment in each operatory must be clearly marked so that dental personnel know which area or item is potentially contaminated, thus allowing the necessary precautions be taken in handling that item. If you are unsure, use a protective covering or disinfectant that item with the appropriate germicide. Bio-Aerosols in the dental setting. A bio-aerosol, bio-living aerosol mist, is a cloud-like mist containing microbes such as bacteria, viruses, molds, fungi, and yeast. Airborne microorganisms can be found in any building. Air conditioning systems, humidifiers, carpets, wall coverings, and plants can easily become microbial breeding grounds. Dental bio-aerosols. In addition to the usual sources of airborne microorganisms, bio-aerosols and splatter in the dental office are even more complex. This is because the aerosols and splatter created during many dental procedures contain oral fluids, blood, dental materials, powder, latex particles, and dust from metal composites and hygiene procedures. Particles that exit the patient's mouth during dental procedures can be separated into two categories. Those particulates that are greater in diameter than 50 microns can be considered splatter. The larger splatter particulates can land on the provider's eyewear, skin, and PPE, or on other spaces and equipment on the floor in the treatment area as far away as 3 feet. The smaller particulates, less than 50 microns, are the aerosols. These remain airborne for minutes to hours, and they can be sources of respiratory infection if they're inhaled. The bio-aerosols and splatter created by the dental handpiece, ultrasonic scaler, and by air abrasion procedures can contain particles of human teeth, oral fluids, bacteria, viruses, old restorations, lubricating oil, and abrasive powder. The use of slurry of certain air water powder products during hygiene procedures, the ultrasonic scaler and air polisher, has been implicated in the creation of bio-aerosols. Aerosols are generated from soft tissue treatments and lasers and electrosurgical units and may contain gases, tissue debris, and other infectious materials. Aerosols can be generated in a laboratory during grinding and polishing procedures. Recommendations for reduction of bioaerosols during all procedures include the use of pre-procedural rinses before treatment, high-volume suction, the use of the rubber dam when possible, as well as the reduction of biofilm prior to procedures by coronal polishing or by brushing and flossing. When the amount of bioaerosol in the environment exceeds the capacity of the air filtration system, allergens, toxins, irritants, and infectious agents will continue to build up. Dental personnel can suffer from allergic responses, infectious diseases, and respiratory problems as a result of prolonged exposure to bioaerosols and chemical irritants. Chemical safety in the dental office. Hazardous chemicals. A hazardous chemical is defined as any chemical that has been shown to cause a physical or health hazard. It can be any substance which can catch fire, react, or explode when mixed with other substances, or is corrosive or toxic. It is the chemical manufacturers and importers' responsibility to assess the hazards of their products and pass the information on to consumers through safety data sheets, SDS. Many dental materials contain more than one chemical. Chemicals can enter the body through inhalation, direct contact with skin or eyes, absorption through the skin, ingestion, eating and drinking, and invasion directly through a break in the skin. Skin and eyes. The skin is an effective barrier for many chemicals. However, some chemicals are absorbed through the skin. In general, the skin must be in direct contact with the chemical for this to happen. Absorption also may occur directly through a break in the skin, such as a cut, open sores, or chapped hands. After repeated contact with some chemicals, a skin disease called dermatitis may occur. Adverse occupational reactions in the form of hand and facial dermatitis are not uncommon in dental personnel. These reactions seem to be most often associated with exposure to acrylics, formaldehyde, latex, rubber additives, which can be a result of exposure to dental materials or the components that make up PPE, personal protective equipment. Other chemicals, such as acids, can break down the outer layer of the skin, causing burns and extremely harmful to the eyes. In the bonding technique for all ceramic crowns, hydrofluoric acid is used to etch the prosthesis to enhance the bond to the tooth. Hydrofluoric acid, HF, is extremely dangerous. Anyone handling this acid must be well informed about the risk and safety requirements in handling the material and how to handle the potential accidental exposure. Eye exposure may result in permanent damage or even blindness. Flushing the eyes at the eye wash station for at least 15 minutes and immediate medical attention are recommended. Exposure to HF is not limited to contact with skin and eyes. Inhalation of this potent acid is of equal concern. Adequate ventilation must be used. Inhalation. Inhalation of materials through gases, vapors, dust is a common route of chemical exposure for dental personnel. Some chemicals can cause damage directly to the lungs in the form of pneumoconosis. Among dental personnel, prolonged exposure to dust containing metal or silica has led to pneumoconosis. Other chemicals may not directly affect the lungs, but are absorbed by the lungs and sent through the bloodstream to other organs such as the brain, the liver, or kidneys, where they can cause damage. PPE, such as masks or a proper respirator and adequate ventilation must be considered and used as appropriate for each procedure. Ingestion. Ingestion, swallowing, is another way that chemicals can enter the body. Eating in an area where chemicals are used and eating with hands that are contaminated with chemicals are common ways of ingesting harmful chemicals. In the dental laboratory, many procedures are performed that produce contaminants such as metal grindings and gypsum products. It is essential to not eat in the clinic or laboratory area, and food should not be stored in the same refrigerator as other dental materials. It is also important to wash your hands thoroughly after contact with any chemical. In many cases, the use of special protective gloves is indicated, and they must be removed and hands washed before food is handled. Exposure to bisphenol A. Bisphenol BPA is what I call it, is a chemical currently used to harden plastics and to line water pipes and metal food and beverages cans. As a result, almost everyone is exposed daily to BPA. An association has been found between higher BPA levels in the urine of young adults and children and increased diagnosis of diabetes, obesity, cardiovascular disease, and liver abnormalities. This is possibly the result of BPA's weak estrogenic properties. However, the current position of the FDA, Food and Drug Administration, is that BPA is not a health concern. BPA is found in polycarbonate, plastics, and epoxy resins. A form of epoxy resin containing BPA is used in some dental sealants and composites. Resins containing the BPA derivative DMA are more likely to release some BPA at low levels over those containing another BPA derivative GMA. Glass ionomer sealants do not produce BPA residue. Dental products are less likely to cause exposure to BPA than consumer products made with plastics and epoxy resin. The U.S. Department of Health and Human Services and the American Dental Association, the ADA, have called for more research to understand the potential human health effect of BPA exposure, especially in young children. There are recommended steps to reduce the incidence of BPA exposure during sealant and composite placement. Each of these steps are important for a successful restorative result. Properly cure the resin. Undercured resin releases BPA. Wipe off the uncured air-inhibited resin layer after curing. This reduces BPA exposure by 95%. Use good placement technique with the rubber dam isolation, four-handed dentistry, and a high-volume suction. Use high-volume suction when adjusting sealants, composites, or orthodontic brackets. Exposure to mercury. There is a known health risk to dental healthcare personnel from exposure to elemental mercury. This risk has long been established, and each office using mercury-containing amalgam procedures must take precautions to eliminate exposure to the dental personnel. Precautions must be taken in the dispensing of the material, placement of the material, condensing and carving of the material, handling and storage of amalgam scrap, and removal of existing amalgam restorations. Because of these precautions, many offices have begun to phase out the use of mercury-containing materials. The ADA Council of Scientific Affairs review of literature on amalgam safety has concluded that the scientific evidence supports the position that amalgam is a valuable, viable, and safe choice for dental patients. Precautions when working with mercury. Work in a well-ventilated space. Avoid direct skin contact with mercury. Avoid inhaling mercury vapor. Use high-volume evacuation whenever removing old amalgam restorations or adjusting new materials. Store mercury in unbreakable, tightly sealed containers away from heat. When preparing amalgam restorations, use preloaded capsules. This avoids exposure during measurement of mercury. Stock multiple sizes of amalgam capsules to minimize amalgam waste. When mixing amalgam, always close the container and close the cover before starting the amalgamator. Reassemble amalgam capsules immediately after dispensing the amalgam mass. The used amalgam capsule is highly contaminated with mercury and as a significant source of mercury vapor if left open. Place empty amalgam capsules in an airtight container marked amalgam capsule waste for recycling. Store leftover scrap amalgam, unused amalgam, in a tightly closed container. Disinfect scrap amalgam that has been retrieved from dental unit traps in a solution of bleach and water. Then place the amalgam in the container with other scrap alloy. Clean stoves. Using appropriate procedures and equipment, do not use a household vacuum cleaner or high-velocity evacuation. Dangerous fumes from the mercury can be released into the air. Place contaminated disposable materials into polyethylene bags, seal them, and dispose of them according to state, province, and local regulations. Acute and chronic chemical toxicity. A toxicity of a chemical and its harmfulness depends directly on the dose, length of exposure, and frequency of exposure. Acute chemical toxicity. This results from the high levels of exposure over a short period of time. This frequently is caused by a large chemical spill in which the exposure is sudden and unexpected. The effects of this type of toxicity are felt right away. The symptoms of acute overexposure to chemicals may include dizziness, fainting, syncope, headache, nausea, and vomiting. Then you have chronic chemical toxicity, and this results from repeated exposures, usually low doses over a much longer period of time, such as months or years. The effects of chronic toxicity can include cancer, neurological defects, nerve damage, and memory and infertility. For example, a single exposure to a high concentration of benzene may cause dizziness, headache, and unconsciousness. Long-term daily exposure to low levels of benzene may eventually cause leukemia. Another example is that of beryllium, a metal used in partial denture frameworks. When grinding beryllium frameworks for adjustment, one must avoid inhaling dust because it is a toxic hazard which can lead to lung disease. A proper mask or respirator must be worn. Personal and chemical protection. Hand protection. Appropriate hand hygiene is the most important step the healthcare personnel can take to prevent the transmission of infectious diseases in the dental setting. When routine dental treatment is being performed, hand washing with plain soap, hand antisepsis with antimicrobial soap or cleansing with an alcohol hand rub should be utilized. Alcohol hand rubs may be effective, however, soap and water is necessary to clean the hands when they are visibly soiled with dirt, blood, or bodily fluids. Fingernail integrity is an integral part of hand hygiene. Nails should be short with smooth edges and not extended beyond the fingertips. Artificial nails, tips, and extenders are not recommended as they may harbor bacteria. If nail polish is worn, it should be maintained with a smooth appearance. Once fingernail polish has been chipped or nails grow out showing margins of the polish at the cuticle, bacterial growth is encouraged. Procedure gloves, patient treatment gloves worn during the patient care do not provide adequate protection when chemicals are handled. When exposed to chemical disinfectants, antiseptics, resins, and bonding agents, the patient treatment gloves may degrade. When degradation of gloves occur, contaminants and chemicals can be pulled through the glove like a whip and onto the hands. Chemical-resistant gloves, such as natural utility gloves, are recommended for wear during chemical handling. With the many materials on the market, the manufacturer's SCS, safety data sheets, instructions should be consulted to determine the compatibility of the glove material with various chemicals. Some individuals develop sensitivity to latex. However, a proper dermatological diagnosis is required before a latex reaction can be distinguished from a sensitivity to some other chemical. To ensure patient treatment, gloves maintain their integrity and protective features. They should be worn no longer than 60 minutes and be changed when moisture on the internal surface is visible, become tacky on the exterior surface, or become ripped or torn. Eye protection. Serious damage to the eyes, including blindness, may result from the chemical accident. It is necessary to protect the eye from exposure to all dental materials, including fumes and splashes, while chemicals such as alcohol, methyl methacrylate monomer, acid, or other solvents are poured. The acids used for bonding procedures can be splashed into the eyes during rinsing from the edged teeth. Protective eyewear with side shields and splash shields are available from many manufacturers and must be worn when handling materials and in patient care settings. Protective clothing, such as disposable overgowns or laboratory jackets, should be worn over uniforms and personal clothing to protect the clinician from bloodborne pathogens and dental materials. The most effective overgowns and laboratory jackets button up to the neck, cover the legs to top and knee when in both a seated and standing position, and have elastic at the wrist. Water-resistant overgloves are more effective in protecting the clinician than laboratory jackets, as the lab jackets are not impervious to liquids. Overgowns and lime jackets are not to leave the facility once worn and potentially contaminated by bloodborne pathogens. Overgowns should be disposed of or sterilized as indicated by the manufacturer, and lab jackets should be laundered in the dental office or processed by a laundry service that specializes in handling biohazardous items. When manipulating chemicals, the type of chemical that is being used should guide the selection of protective clothing. A rubber or neoprene apron should be worn when one is mixing or pouring chemicals that are causative, can stain, or would saturate, penetrate, or damage regular fabric. Inhalation protection. Patient treatment masks are necessary to protect the clinician not only from the spread of infection but particulate matter described earlier in the chapter. During routine dental treatment, the mask should be changed after every patient, every 60 minutes, or when it becomes damp or wet. The necessity to change the mask frequently stems from the mesh in the mask beginning to break down after 20 minutes, which causes the protection of the clinician to decrease the longer the mask is worn. The mask worn during patient care may or may not provide adequate protection when one is working with chemicals, depending on the quality of the mask. The face mask should be fluid, repelling, and provide respiratory protection. If the job requires frequent pouring or mixing of chemicals, sensitive or allergic individuals might need a National Institute of Occupational Safety and Health NIOSH approved dust and mist respirator face mask. Several masks are on the market for personnel with sensitive skin. These masks are free of dyes and chemicals and have a lint-free cellulose inner layer. Control of chemical spills. Mercury spill. Mercury spill kits should be available in all dental offices that use amalgam for restorations. Exposure to even small amounts of mercury is very hazardous to workers' health. Mercury can be absorbed through the skin or by inhalation of mercury vapors. The spill kit for small amounts of mercury should contain mercury-absorbing powder, mercury sponges, and a disposable bag. A mask and utility-type gloves should be worn when cleaning a mercury spill. Flammable liquids. Many solvents used with dental materials have a very low flash point and can easily ignite when used near open flames, such as a Bunsen burner or an alcohol torch. Take extreme caution when using flammable products. The SDS for each product describes the flammability of that product. Acids. As mentioned previously, phosphoric, hydrofluoric, and hydrochloric acids are used during manipulation of various dental materials. Splashing any of these acids on the skin, eyes, or clothing can cause severe burns or damage. Flushing with water immediately is essential to prevent severe injury. Eyewash. OSHA. Regulations require an eyewash unit to be installed in every place of employment where chemicals are used. A wide variety of styles are available. The standard eyewash unit attaches directly to existing faucets for emergencies, yet still allows normal faucet use. When turned on, the eyewash unit will irrigate the eyes with a soft, wide flow of water as necessary to bathe away contaminants without causing additional damage. As an employee, you must be trained in proper use of eyewash station. It is recommended that eyewash stations be inspected frequently to ensure water flow. Some manufacturers suggest running them for several minutes periodically to discharge any potential built-up biofilms or infectious agents. A posting of suggested time for eye washing after an exposure and direction for the proper use of particular type of eyewash unit should be placed nearby the eyewash station. Ventilation. Good ventilation is a necessity when dealing with any type of chemical. Dental offices should be equipped with a special exhaust system for fumes and dust in the laboratory and in radiograph processing areas. For example, vapors from chemicals used in radiographic processing can cause contact dermatitis and irritation of eyes, nose, throat, and respiratory tract. Other laboratory areas may be laden with fine dust particles from grinding or chemical vapors such as from acrylic monomer or picoline acid used to remove oxides from cast metals. General precautions for storing chemicals. All dental materials contain chemical components, and some are more hazardous than others. Careful use and storage of dental materials is essential to ensure these products retain their therapeutic activity and identity. Changes in the chemical composition of materials can occur for many reasons. When changes take place, the product may no longer retain its self-effectiveness. Expiration dates must be reviewed, and out-of-date materials should be disposed of properly. A basic safe policy for the storage of dental medications and chemicals is to keep them in original containers when possible in a dry, cool, dark place where they are not exposed to direct sunlight. Many single-dose products have been developed to eliminate cross-contamination and reduce effectiveness of the product due to evaporation and contamination. Disposal of chemicals. Empty containers. Even empty containers can be hazardous because they often hold residue that can burn or explode. Never fill an empty container with another substance because a dangerous chemical reaction could occur. Follow the label in the SDS on how to dispose of empty containers. Hazardous waste disposal. A waste is considered hazardous if it has a certain properties of chemicals that could pose dangers to human health and the environment after being discarded. In general, waste is classified as hazardous if it has any of the following: if they're ignitable, corrosive, reactive, toxic. Listed by the U.S. Environmental Protection Administration, the EPA, and the Canadian Environmental Protection Agency, CEPA, several hundred chemicals are listed by the EPA, CEPA as hazardous chemicals. Regulations for hazardous waste disposal vary among states and provinces, and heavy fines may be imposed for those individuals who knowingly violate regulations. More important than legal penalties are the environment damage and the pollution of surface and groundwater that can result from improper handling, transportation, and disposal of hazardous waste. The solution from the wet processing of dental radiographs are not permitted in the public sewer systems, and if they are disposed of in private sector systems, they can cause those systems to fail. The disposal limits, either down the drain or in a landfill, or X-ray film, lead foil, disinfectants, and acid edge, are also regulated by either county and state regulatory agencies and can vary widely through the United States. An example of a regulation that can improve wastewater groundwater is a regulation requiring use of amalgam separator. The Environmental Protection Agency mandated under the Clean Water Act that in July 2017, dental practices must control amalgam waste through the use of amalgam separators certified by the International Organization for Standardization, ISO, Standard 11143. These separators can remove 95% of the amalgam fine waste and prevent it from going into the sewer system. Mercury from dental amalgam can end up in the soil, atmosphere, and groundwater through several routes, including wastewater discharges from dental practices, as well as throwing out amalgam scrap in the dental office. Waste. Mercury from dental amalgams may also be released through the burial and cremation of individuals with amalgam restorations. The amount of mercury released from the dental amalgam and the result of the conversation into the ecosystem is highly variable. The aquatic and soil contribution of mercury from dental amalgams is considered to be very low, and there have been several improvements to the regulation and the disposal of scrap amalgam in many states. The ADA has provided a best practices management for handling amalgam with the intent of reducing amalgam release into the environment. Dental laboratory infection control. OSHA mandates that dental laboratories have the same infection control protocols as the dental office. Dental laboratories may be part of a dental office or be off-site and owned and operated by dental laboratory technicians not employed by the office. Effective communication must be established with facilities within the office and off-site to prevent disease transmission from contaminated items entering the dental laboratory. In addition, dental laboratories are obligated to make sure that the products delivered back to the dental laboratory are free of contaminants. Dental laboratory technicians must adhere to the same standard precautions for the prevention of health-related diseases from the materials they handled. For example, impressions, casts, and dental prostheses are often moved back and forth between laboratories and dental operatories. These items may be contaminated with blood, saliva, which allows microorganisms to be transferred to the laboratory environment and back to the dental operatory. Microbes have been cultured from set gypsum dental casts for up to 7 days. Good communication and standardized protocol are essential for effective infection control. If there is ever a doubt as to the status of an incoming or outgoing case, the appropriate disinfection process must be completed before the item can be handled or placed in the patient's mouth. Infection control communication between lab and dental office. Disinfection status of incoming and outgoing cases. Utilization of appropriate shipping and receiving containers. Designated receiving and shipping areas and protocols, and designated production areas. All equipment used in the dental laboratory must be single-use items or handled with standard precautions for prevention and cross-contamination. Even though cases are appropriately disinfected before entering the production area, dental layers, handpieces, burrs, brushes, rag wheels, and other laboratory equipment should be disinfected or sterilized daily. The dental lab should be protected with a functional shield surrounding the lab to prevent spatter, aerosols, and the possibility of flying debris. Appropriate PPE must be worn in the dental laboratory to protect individuals from biological contaminants, bio-aerosols, and chemical contact and inhalation. Appropriate ventilation and air or suction motors are important for these areas. The dental offices and dental laboratories must follow the same infection control guidelines to protect healthcare personnel and patients from bloodborne pathogens. Standard precautions, appropriate personal protective equipment, and good communication between the laboratory and the office are all components of successful infection control procedures. Occupational Safety and Health Administration Hazard Communication Standard. OSHA has created standards to protect the safety of workers. Dental office personnel should be very familiar with bloodborne pathogen standards. This section addresses the standards that protects workers who are at an increased risk for chemical exposure. The Hazard Communication Standard. OSHA issued the Hazard Communication Standard because employees have the right to and the need to know the identity and hazards of the chemical that they are in the workplace with. The Hazard Communication Standards are also known as the employee right to know the law. Require employers to implement a hazard communication program. Hazard Communication Program. OSHA has been enforcing a Hazard Communication Standard, HCS, since 1983. A chemical hazard communication program has 5 parts: the written program, the chemical inventory, the safety data sheet, labeling of containers, and the employee training. Eco-conscious green practices. What about protecting your office and the environment? The process of preventing the transmission of disease and performing dental procedures involves equipment and products that produce waste, consume excess energy, and use toxic chemicals. To accomplish this, there are traditional and environmental friendly products, supplies, and procedure available. The average dental practice disposes of hundreds of pounds of paper and plastic waste each year. They must be effective compromises to maintain an eco-friendly practice while not compromising the safety of the patient. Patient safety. It is extremely important for the health care provider to consider the safety of the patient while care is given and various materials and chemicals are used. The summary. The management of a safe environment in the dental office is the responsibility of the employer and all of those that work there. The safe use of any chemical or material is the responsibility of the user at the time. The safety of the patient is the responsibility of the dental team. Familiarity with each material or chemical used by the dental team is a must. This text provides general and technical information, but specific hazards are best determined by referring to the manufacturer's instructions and the SDS. Keep yourself informed, keep up to date with the standards, and continue to inquire, how can I protect myself, my patients, my fellow workers, and the environment?